Hello, everyone. Welcome to the North American Spine Society COVID-19 Case and Recovery Updates from the International Spine Community webinar. Thank you for joining us today. My name is Patrick Shea. I'm a spine surgeon from USC Spine Center in Los Angeles, California. A few pieces of information to go over before we officially kick off the session. For the audience, all questions can be asked using Slido. Please go to slido.com and enter the code hashtag NASS-COVID to join the session. If you have specific questions for a specific speaker, please include your name as well as his or her name, and the speaker will address the questions at the end of the webinar for you. Please note that the questions can only be seen by NASS staff as well as the speakers. Please also email bschaefer, B-S-H-A-E-F-E-R @spine.org with any question or concerns during or after the session, and a NASS staff member will respond to you promptly. A quick disclaimer before I introduce the speakers. The views expressed in this webinar are solely those of the speakers. This webinar is intended for informational purposes only. It's not a substitute for any advice from governmental organizations, agencies, or institutions. NASS strongly advise participants to continue to consult with your professionals and advisors familiar with your situation when making decisions in this rapidly evolving landscape. With me today are 7 distinguished speakers from various parts of this world. With us today are Dr. Abu Bakar from Kano, Nigeria. He is the current president of the Nigerian Spine Society, as well as the chief of spine surgery and National Orthopedic Hospital in Kano, Nigeria. We also have Dr. Tayar Barano Carl from Bangkok Spine Academy. We also have Professor Bambang Darwano from Jakarta, Indonesia. Dr. Astrobal, Professor Astrobal Felix Magna from Casillas do Sol. Dr. Scott Kleiner from Barrel's Brain and Spine Institute in Phoenix, California. Dr. Professor Tariq Sahil in Lahore, Pakistan. And then Dr. and Professor J.C. Wu from Taipei, Taiwan, from Taipei Veterans General Hospital. So moving on to our agenda, we will go ahead and start with Dr. Brianna Carl from Bangkok Spine Academy. Again, we have, if you see our agenda, there are 3 parts to our agenda. The first part will be focused on current status. The second part will be really recovery, status of recovery or planning. And the third part will be discussions and questions. So for the updates on our current status, please, for the speakers, address the current impact of COVID-19 pandemic to your country, your local community, your hospital, how it's impacting your surgeries or procedures, how it's impacting your patient, and are there any resources or challenges in the gap of your ability to manage COVID, and we'll have all the speakers address these points based on their experience with the COVID-19 pandemic. So I will turn this over to Dr. Brianna Carl from Bangkok, Thailand. It's about 9 p.m. in Bangkok, Thailand, I believe. Dr. Tayar, can you please unmute yourself and begin with your update?
Thank you, Patrick. Can you hear me?
Yes.
Yes. Okay. For Thailand, we have doing well about the COVID infection in our country. For the starting of the COVID infection, we start on the early of January. At that time, we have only 1 or 2 cases, but around 2 months later, after January, this is an eruption of the infection. I will show you on this one. You can see that this is on the starting time, and case is rising 2 months later, and we have very high infection rate about the middle of the March. And after that, we try to control. For the case, the pandemic is increasing in which two center. The first one is in the sport center of the boxing sport centers. And the second one is it's starting at the party in the middle of our town. After the starting of the infection, we try to control very well by our government. And right now, the curve is slow down and falling. Today, we have only 30 cases of the new case. We are doing well. Total case of the infection, we have around 25, around 2.5 thousand cases, and we have case of death around 50 cases. So I think our health organization have doing very well to control the infection of the COVID. About our situation in the spine, on the middle of January, after we know that we might be faced with this problem, my hospital, my government hospital, I also working in a government hospital in Air Force Hospital. They cancel all the elective cases until now. But also in the Bangkok hospital, which is a private hospital, the case coming to see us and apply for the elective cases coming down abruptly. But anyway, we still have around 20% of the elective case still have appointment and operate in each week. So about the policy of the hospital, we are very strictly in terms of we try to we have point to discriminate the case, to check up the case that coming in our hospital very strictly. If the case has history of the risk, have the risk history that contact to possible to contact the COVID case, there might be waiting at least 2 weeks before surgery. But in the case that have safe history, we have the policy to check the PCR for COVID at least 48 hours, not more than 48 hours before elective case surgery. About the standard guideline, the guideline for surgery is the same. We still doing everything the same as the surgical technique as we do, except about the anesthesiologist needs to wearing the PPT suit case to protect themselves. And for me, if the case have the risk history that shall be infected with the COVID, we will wearing very fully protection suit before surgery. That is our situation. My elective case in government hospital and my friends in our society, elective case in government hospital still cancel the appointment right until now. Okay, that is all. I think I will leave the time for another speaker. Thank you.
Thank you very much, Dr. T.R. So our next speaker is going to be Professor Dewano from Jakarta, Indonesia. Dr. Bambang Dewano, please go ahead and unmute yourself.
Okay. So our country is number 4 populous country in the world, number after the United States with a population around 265 million. And the first case of COVID-19 was reported in the 2nd of March, just 2 cases. But now already 50 days after 2nd of March, the cases increase a lot. So I can show you. The first is in Jakarta. Now we have this number of cases. And at the beginning of March, the death cases is higher than the healing cases. But nowadays, the healing cases is higher than the death. So the ratio is turning in another way. It means that even the case is increasing. Now is spread all the part of the Indonesia and still increasing. Here you can see up to now is still increasing. Only the healed cases is getting higher than the death cases. Why? Because like traditional in Ramadan, people who walk in Jakarta, the most populous city, then back to the country, and they can infect it another people. Now, already around 7% of the people go to the countries, but still 93% keep in the city. The highest part is in Jakarta. That is the epicentrum. Now the government make a partial lockdown. They are not allowed to go back to the country for this time to prevent the spreading of the cases. But what is the impact for the people? People in low economy and get the income from daily working, they got the most worst impact. Because so what we do now, not only the government but the community then try to find a funds and to help them for the foods and also to help for the personal protective equipment like a mask. They should wear masks when they go out from the house, and also gown and Google or gloves. So impact in the hospital. I'm now working in the private hospital because I already retired from the Army Central Hospital. The regulation now, if patient come to my hospital, they will be checked with the CT scan and X-ray. If they have the sign of the infection, pneumonia, then it will be sent to the referral hospital. There's already they already designed to treat this kind. So my patient also, when I for elective come to my hospital, will be checked first. If that is okay, then we can continue to help them. And this in the 5th of April reported that already 24 doctors passed away because of COVID, and a lot also of nurse. So the last report in a government hospital, the patient doesn't talk honestly that he already contact with the COVID. Then what happened? When he already detected that he's already infected with COVID, then the director checked 800 people, doctors and the nurse and everybody with the rapid test. And then they have 51 doctors and nurse positive. Rapid test doesn't mean always COVID positive because they do a swab and take someone. But then they isolate these 51. It means the work in the hospital will be decreased because the doctor is not allowed to serve the patient. So this is all the impact of the COVID in my country. This is still increasing, but hopefully with this partial lockdown, they can control. But the good thing is that the ratio between the healing and the death now is turning in different ratio. Previously, the death is higher than the heal. Now the heal is higher than the death. So that is all the problem in my country.
Thank you very much for the updates on Indonesia, Professor Dewano. We will move on to Dr. Falavinga from Brazil. Dr. Falavinga, can you please update us on the status of Brazil, where you're at with the current COVID pandemic?
Absolutely. Thank you for the invitation. I think that we will never have predict such an intensive change in our life as observed here in Brazil. Just to have idea, the population in Brazil is just over 217 million people with an area of 8.5 million square kilometers. That means it's not homogeneous, the impact of COVID in Brazil. We have some areas that we have more patients with COVID than other areas. So Brazil is a huge country. The infection and deaths are widely from state to state. The COVID curve is rising in Brazil. The elapsed time from the first case from now is 2 months. We are about 2 or 3 weeks behind US. Some places like São Paulo and Rio de Janeiro had already overloaded the health system. The number of confirmed cases was around 41,000 patients, 6% mortality rate. I live in the south part of Brazil where we are approaching the winter season. So we expect this have some impact in my region, in my state. Currently, the number of cases in my state is 2.3% of the Brazilian case. So it's very lower in the number of cases. We had a total isolation of 3 weeks that was progressively relaxed according to the random test that we perform on the population. Shops now are open with certain restrictions. School will be reopened next week in line with some state regulations. The isolation has been relaxed and many precautions established, like wearing masks. We cannot leave home without mask. We need to wear mask, avoiding agglomeration, washing their hands. I think that's the same that we can find in every country. Elective surgeries were canceled and postponed for a second time. The only problem that we cannot keep postponing the patient. Sometimes the patient is urgent. So now we have progressively start to have some elective cases scheduled. And the problem is that the patient are still afraid to go to surgery right now. So when the case can wait, we do CT and we do the COVID-19 test. If it's not possible to do the test, we do our best to protect the patient, the staff, and ourselves. We keep the rotation of surgeons in the operating room to minimize the personal overload of virus. And how I keep tracking the patient, I perform remotely the spine patient consultation and monitoring that time. On that time, I was wondering how I could help more people through innovation and by leading multidisciplinary teamwork. I start a community-based program of teleconsultation to help people, not only spine, but people in general with clinical symptoms, orientation about isolation, problems with anxiety, depression. It's wide, enormous, the problem that usually the population has with that isolation. So the main barriers to overcome this COVID period are the lack of personal protection equipment. We have reduced number of diagnostic tests. The cultural issues is not all the community that follow wear masks and everything. So we have some cultural issues that we need to deal with. And we have a scarce number of ICU beds. But my point of view that even during the tragedy like we are having right now, we need to have always a positive foresight of the situation. And I still remember, when there is a need, there is a way to do. So I still think, and I think that the next time that we're going to talk about is about innovation. How beautiful is the innovation this time? So that is like an overview in Brazil.
Thank you very much, Dr. Felligna, for that wonderful update on Brazil. We will next introduce Dr. Scott Kreiner from Phoenix, Arizona, in USA. Scott, could you please unmute yourself and give us an update on Arizona and the status of Phoenix and your local community? Thank you.
Hello. Thanks for inviting me to be on this call. For those not aware, I'm currently in Phoenix, Arizona, which is the 5th largest city in the United States. We had our first case of COVID-19 here in early March, and our first death in mid-March, around the 13th. About 4 weeks ago, the governor canceled all elective cases in the state. In our state, we've closed down all restaurants and public gatherings and done what I think most people have done in the United States at this point. We've seen in our state, we've done a very good job of controlling COVID-19. We have increased our number of tests in the state. Currently, we've tested about 56,000 patients, of which we have 5,500 cases of COVID-19 and just over 200 deaths related to COVID-19 in our state. We haven't seen the impact on our hospitals as we were expecting because we've done such a good job at flattening the curve in our state. Currently, about 10% of our hospital beds are filled with COVID-19 patients, and about 20% of our ICU beds have COVID-19 patients. So because of our ability thus far to flatten the curve, the governor decided yesterday that he's going to lift restrictions with regard to elective surgery starting on May 1st and allow us to begin doing elective cases in Arizona again on May 1st, which is nice. We've done what I think probably many of you have done is with regard to seeing patients in the office. We're doing a lot of that by telemedicine right now, and that seems to be working fairly well, though there's certainly some limitations with that, I'm sure, as everybody is aware of. But currently right now, things are I think probably as good as they can be in Arizona, though, we're seeing impacts with regard outside of healthcare with regard to unemployment and a lot of businesses not being able to maintain their function. And so we'll see if we can open up the economy soon. I think it's going to have a very large impact on a lot of areas outside of healthcare. So that's where we are right now in Arizona. And I know that all of my colleagues here at Barrow and throughout the state are looking forward to resuming elective cases as we take care of a lot of spine patients. So I think that's about the update that we have in Arizona right now. Pat.
Thank you very much, Scott, for that nice update on the status of Phoenix and Arizona. Our next speaker is going to be from Pakistan. Professor Dr. Sahil from Lahore, Pakistan. Could you give us an update on the status of the COVID-19 pandemic and its impact on your community and your country?
Thank you, Patrick. It's a greeting and good day from Pakistan and from my side, and I wish all of you a healthy stay for yourself and your family and all the people in their respective countries, so they are protected from this pandemic coronavirus or COVID-19. Pakistan is a unique country because it has a strong and large border with Iran, which is a very heavily infected area. And then we have border with Afghanistan and China. And then we have border with India. But luckily, we just have a first patient on 26th of February, and then gradually we increase the number of patients who presented with a clinical illness that later on they got tested. And so far till today, we have 10,811 patients who are COVID-19 positive. And out of those 2,377, they have recovered fully and they are back to their normal activities. And the only 60 patients out of 10,800 or so, they are critically ill. They are needing some kind of respiratory support in terms of ventilation or heavy dose of oxygen and etc. And only 228 deaths have been occurred during so far last month and a half. And if you look at the number of this is the curve which we have. This is, you can see it is rising up, and it is the number of patients, they are increasing over the period of time. The number of patients, they are increasing. There have been some problem with the Pakistani community by and large, because the average population, education level is something like 53 or 50% around. So there's a 50% people, they are illiterate. They do not know a lot of things, or they do not understand the gravity of the situation. And the average age to the latest statistics is 67 years or so. And if you look at the economic index, the 40% of the people, they were below the poverty limit or so. There are various parameters for the poverty, but this is the kind of average in which we are. So there's a lack of education, there's a poverty, and along with that, there is some religious element as well, because the people who have been infected, they have been bringing the disease from neighboring countries in which they have been going for the pilgrimage. And they have been also certain religious sect which have been confined to a certain area, and they have been infected, and they have been infecting and spreading disease and other. So they have to be rounded off and cordoned off in a certain area by curfew means, because they couldn't understand the gravity of the situation. So the army have to be called in, and they have to be confined to the area. The curfew has to be imposed so that they do not leave that area, whatever that happens. So by that, we have controlled disease to a certain extent, and the rise of the number of cases is not exponential by Western standard. We have increases, we have some peaks, then we have number of new cases going down, then again rising up. But I think overall the trend is going upwards, though the number is not exponential. It is much more much below the expectation. We have some relaxation of the confinement rules for last week or so. So we expect that number of cases will increase over the period of time, maybe in the first or the second week of May, and then we see what happens. But by and large, it has been not so extravagant, or the not so high number of patients who are COVID positive, and the number of patients who have recovered is going increasing in size and number. Coming to the clinical situation, the government has stopped all the outpatient departments for last 4 to 5 weeks or so. So are the private hospital. We are not taking any scheduled cases, the cold cases, but those who need urgent care, they are admitted, and those who are in emergency situation, they are taken care. And all the patients whosoever come to the hospital, whether it's emergency or in the scheduled case, but they need urgent care, they are screened clinically. Their contact is explored, and any travel history that has been documented. and all the patient who has a minor sort of suspicion of any infection or systemic illness, they are screened both for the gamma globulin and the IgM and IgG, but also if the clinical suspicion is strong, then the COVID-19 PCR is done, and then they are admitted. But in emergency situation, then they have to be sort of treated as it is. In the meantime, their COVID-19 infection or suspected infection is ruled out. Coming to the clinical working condition, we clinicians we do the all the protective gears are in place. We are covered from head to toe with sort of protective equipment, and we wear goggles, and we wear either a face mask or similar device, and we try to get the N95, but it's not very freely available. But nevertheless, the equivalents are available, and we use similar kind of mask on a regular basis. In the theater, we have sort of scheduled the staff. All the staff is not there at the same time. They are scheduled in shifts so that the contamination and the number of viral load which potentially they can carry is minimized. And all the staff which is there in the hospital or in the theater particularly, they are screened for any potential infection, and they are screened well before, and they are screened or checked regularly clinically so that they do not carry any clinical suspicion of infection, or if they are suspected, then I think PCR is to be done in this case. We have recently, I have been involved with telemedicine, and the telemedicine in this difficult time is much more useful. We are, various agencies, private and the government, they have telemedicine facility available. We get a regular consultation on telephone and occasionally on the video, and they tell us, but again, as Scott has said, that there's certain limitations. You cannot decide on this telephone call that what to do or not to do. And but nevertheless, the patient can get their symptom to be heard, and ultimately some advice is given, and if there's any need, then a patient can be called in depending on the urgency of the situation. So I think bottom line is that at the moment we have a reasonable number of patients, 11,000 or so, out of 21 or 22 million population. This is not a huge number, and the rate of addition of new cases is not as exponential as in West. I think there was some sort of theory that in the northern hemisphere and the southern hemisphere, they behave in a different way. Northern hemisphere, the number of patients is increased, there's exponential growth, and the number of mortality and morbidity is quite significant. Whereas in the southern hemisphere, which have this Asian countries, which lo and behold, they have a poor socioeconomic status, but the number of the patient is much less as compared to. There may be certain factors. We all have been vaccinated in childhood with the BCG. We all have been exposed to various kind of polio sort of viruses at certain stage, though majority didn't have any tuberculosis or polio infection and any sequelae after that. And we still have been exposed to a lot of viruses, either through the air or through some other means. And I think by and large, we have some immunity there. I'm not sure whether it's a herd immunity or not, but I think as a subclinical exposure, because the number of patients being tested is still low, because we don't have the kits available for testing. So I had a feeling that a lot of population is being exposed. They develop subclinical infection, or they are asymptomatic and they get away without producing any symptom, without being apparent. So I think over the period of time, we are developing what is called as herd immunity, and I think that may be playing some positive role in our society in the present scenario, despite very poor in equipment, very poor in testing facility, very poor in other mode of treatment or management being available in our setup. At the same time, the government doesn't have that much financial capacity to lock down all the industries and people from the work. So they have relaxed certain lockdown conditions, but they have to observe the distancing rule. They have to wear the mask. They have to, if they are professional, they have to wear the gowns and etc. And if they are exposed to public dealing, they have to wear that. At the same time, government has done a great job. They are giving a stipend to the people who cannot afford. They are without job, and I think that has given some relief and some benefit to the masses at large, because as I said, the poverty line is something 40% or so, and quite a number of patients they do need some financial assistance, and government is to be applauded for that, and I think they are doing great. Thank you very much. I'll add on whatever is necessary as we go on along. Thank you.
Thank you for that excellent update on Pakistan, Professor Sahil. Our next speaker to provide an update on the status of Taipei, Taiwan would be Dr. J.C. Wu from Taipei Veterans General Hospital. Dr. Wu, would you please provide us an update?
Thank you, Patrick. And I'm happy to see everyone here. And it's my honor to share the experience in Taiwan here with everybody and with all you guys. As a country so close to China, we are an island in West Pacific. And till today, we have a total of 58,003 patients tested for COVID-19, and we only have 427 confirmed cases and 6 deaths, and 253 patients recovered. That recovered means they underwent 3 times of RT-PCR to turn negative. Then we can stop the quarantine. And as today, we have 1 new confirmed cases. So we're doing pretty good job here. The government is doing pretty good here. And because one of the reasons is because we started early. As you can see, we're so close to China, and we have this unique relationship with China and Taiwan. So the government kind of to start this these strategies to try to stop COVID-19 early. We can trace back to January, where we started to test the COVID-19 viruses, and we have the first confirmed cases as early as January 2nd. And the government tried a lot of ways to stop the infection from transmission. And this is a slide from the Center of Disease Control of Taiwan, and they advocate people wearing masks. So we are one of the few countries where kids can still go to school, and we still have pro baseball playing, although without any audience, just the players and the referees. And the government encouraged people to wash their hands, and there's sensitizers everywhere. You can't go on a bus or train without wearing a mask. And they advocate social distancing for any inside area. We need to keep at least 1.5 meters from each other. And not only the medical professionals, but also the government discourages people from traveling abroad. And this is the strategies the CDC of Taiwan suggested to stop this COVID-19. First of all, we need to do the surveillance. I think we have quite an amount of patients tested. Generally, we are testing every patient who is febrile or whoever has pneumonia or whoever has suspected contact history. So anyone who's admitted to the hospital for his elective surgery has to be cleared for any contact or any possible contact or any fever in the past 14 days. And for border control, the government has been very strict on that. In fact, out of our 400 something cases, most of the cases were imported cases, or most of them are returnees from overseas. And there are less than 100 locally acquired COVID-19 cases. And of course, we tried very hard to control community transmission. And just recently we got this, we had a Navy supply ship that came back with 27 or something, 27 people or sailors are contracted with COVID-19. And so far there's no nosocomial infection in our hospitals. We happen to, there's one delayed diagnosis of COVID-19, but they shut down the ward, and basically that case stopped right there. And we have been doing very good job for stockpile and allocation of the PPE and other medical supplies. Taiwan is one of the countries that first stopped exporting masks, and the government started to manufacture the masks in our own country, and every citizen can buy 9 masks every 2 weeks, starting that's 2 weeks ago. And the last thing I think is also very important, health education and fighting disinformation. Nowadays, there are all these fake news that will make people panic. So our government hosts a pressure conference every afternoon at 2 p.m. And every case is tested, and confirmed cases are reported to the public. So I think the government has done a good job in preventing fake news or fighting this disinformation, because I think in this pandemic time that really will get the situation worse. And again, from my personal point of view, I think surgical masks did work. I think it's very important, and I suggest everyone should wear mask whenever you contact others until the world finds the vaccine. I think this will be very important. And the other things I think the Taiwan has done a good job is that the government controls entrance very strictly. You have to show an ID, and you have to show a permit to get into our hospital, and you have to declare that there's no contact history, and of course they use a thermometer to measure the temperature. Once it's over 37.5 Celsius, that is 99.5 Fahrenheit, you cannot enter the hospital. And once you enter the hospital, surgical mask is required all the time. And for every hospitalized patient or every elective surgical patients, there are very strict screening protocols. For example, if I need to schedule a shunt surgery tomorrow, the patient who has a hydrocephalus, but she's been febrile since 2 days ago, then she has to undergo at least twice of the COVID-19 RT-PCR test negative, then she can undergo the surgery. Only if it's a life-saving surgery, then all these surgical staffs have to wear full protection. That means with N95 plus surgical masks and goggles and everything. That's the only way we can go through proceed the surgery. And so I think Taiwan is one of a few countries has done so far a good job that controlled the COVID-19, but we are still facing a few outbreaks. Like I said, there was a Navy supply ship that has 700 something people on board, and they just landed the other day, and there are so far almost 30 cases confirmed, and with all the contacts, so we're facing another outbreak. So, but we're still doing elective surgery. Kids still go to school, and you can see most of the business are still slowly running. And I suggest I think the world will be recovered soon, and just most of us will need to wear masks for the coming months to come, I think. And thank you, Patrick.
Thank you very much, Dr. Wu, for that excellent update on the status of Taipei and the great job you guys are doing for your people and country there. Our final speaker would be from Kano, Nigeria, Dr. Abubakar. Dr. Abubakar, could you please unmute yourself and give us an update on what's going on in Nigeria?
Thank you, Patrick. My name is Dr. Kabir Abubakar. I'm the president, Nigerian Spine Society. As you are aware, Nigeria is on the west coast of Africa, the most populous Black nation with a population of around 200 million. COVID entered Nigeria through our airport in late February of this year, and immediately thereafter, government took some measures, which included closing all major international airports and initiating of contact tracing, following which few contacts of the index case were traced, and that led to concentrating activities in the area through which he entered, which was Lagos, Nigeria, the commercial capital of the country and the neighboring state. A few weeks later, some other cases came up in other parts of the country. We are divided into 36 states for administrative governance. So as of now, the largest, almost 80% of cases are concentrated in three major cities. The city of Lagos, the first point to identify the index case, the administrative capital of Nigeria, which is Abuja, and the city where I live, which is also the second populous city in Nigeria with a population of close to 5 million. So those three cities account for almost 80% of the cases we have now. The confirmed cases in Nigeria as of yesterday stands at 873, out of which about 279 have been discharged from treatment centers. So far, COVID-19 related deaths are about 28. And as in most parts of the world, there's a significant mortality involving healthcare workers. In fact, of the 11 first deaths, 3 of them were medical doctors. So we also face the challenge of involvement of healthcare personnel. On the part of government, there is a National Center for Disease Control already in existence, because we already had challenges of some other viral challenges, especially Lassa fever, which, as you might know, is a very rapidly fatal hemorrhagic fever. And then also some years back, we had an Ebola virus outbreak. So we have had some challenges with viral infections before now. So the government set up a presidential task force to monitor this. Most of the state governments also set up their own task forces. Subsequently, there were lockdowns, especially in these 3 major cities that I mentioned earlier. In fact, as of today, in Kano, we are just on a lockdown break before the holy month of Ramadan, which is expected to start tomorrow or next, so that people can do some shopping. Otherwise, we have been under total lockdown for the past 1 week. Before then, the initial effort was to lock the state borders to prevent entrance and exit from the state. So all these measures, some a little bit too late, some not adequately enforced. And the situation right now is that we're in a state of community transmission. And that is very distressing. On the part of the government again, there has been challenge with test centers. For the 200 million population, we now have 13 test centers. So when I hear that in some institutions, you will actually do tests before elective cases, that is far from our own reality. Sometimes it takes days to get results of the PCR test. And we've been told that the rapid tests are not yet well certified, so they are not used frequently here. The implication of that is that when we have emergencies, we really do not have the capacity to screen them before attending to them. All we do is to try to take maximum precaution, which again is limited to N95 masks, at least in my institution, N95 masks and face goggles, and essentially regular protective wear, not the specific PPE, which is more protective in this setting. So the challenges will relate to, I believe, inadequate testing. We need to beef up on testing. We need to be able to identify those who come with other surgical emergencies that might actually be COVID positive. With regards to the populace, the lockdown has been very challenging because schools have been closed, businesses are closed in all these cities, and knowing where we fall in the terms of general economy, the statistics of how many are living below poverty line, I think is not for this medium. But in such a setting, when you now close down all businesses, it's been quite tough on the populace. Again, government has been trying to make efforts to distribute some palliatives. How far that is getting to those that need it is something to be examined. And then when it comes to clinicians, there have been guidelines generally, which have been useful to us. One of those that we looked at as the Nigerian Spine Society was that released by North American Spine Society, the NASS guidelines, where patients are classified into emergent, elective, and so on. And generally speaking, we suspended routine elective surgeries. Like I said, we still do emergency surgeries at considerable risk to the health workers. We do not run regular outpatient clinics. We are encouraging telemedicine, even for our departmental meetings now. We are increasingly going electronic, as with this meeting. And we essentially are not as productive as we would like to be. But like I summarized, the main challenges are that not enough testing is being done. Of course, there's a world's scarcity of protective equipment. I've just been told that Taiwan stopped exports, as with many countries that produce some of these things. So we're running into shortages of some simple equipment. And we are hoping that the exposure of healthcare workers will not lead us into a worse crisis when we won't have adequate people to take care of those that might come down with the disease. And nationally also, the other thing is that the challenge of COVID-19, I think, brought attention to some of the weaknesses in our healthcare system. Because when most patients are deemed to require intensive care support, including ventilators, we suddenly started taking statistics and found that what we have nationally, quite small in number. We're also a little bit concerned that the treatment centers have been set up as isolated units rather than use the opportunity to improve existing health facilities where these things can be of continual use after the pandemic. So essentially, Nigeria is affected. It's now at community infection stage. We don't have adequate testing. We don't have adequate protective equipment. But luckily, the mortality has not been very high. 28 in a population of 200 million is significantly manageable considering what is happening in some other parts of the world. And we do hope that whether it is, as was discussed earlier, our geographical location, the ambient temperature, our previous immunizations and exposure to various immunological challenges, whatever it is that is keeping our mortality low, we hope will continue to support us. But definitely, it is not the strength of our healthcare infrastructure. I think that summarizes the situation in Nigeria. We probably have a few more to say during question and answer. I apologize for my late joining. My initial equipment was faulty, so I had to switch to another equipment. I'm glad that I'm able to join you at last. Thank you for having me.
Thank you very much for that excellent update, Dr. Abubakar, about Nigeria. So before we move on to the questions and discussions, I would like to spend about 10 minutes on some discussion about recovery and where we're at or how we're planning recovery with at least part of our speaker panel here. You know, it sounds like to me that based on our speakers today, about half of the countries are still seeing the rising number of cases with COVID pandemic, and about maybe half of you are starting to see some lifting of restrictions, whether it's some type of lockdown or shelter at home restrictions. So I want to just touch base with some of you regarding that subject. So I'm going to start with you know, Dr. Fellow-Vignat about Brazil. You know, we hear that Brazil is starting to lift some of the restriction. I know your region is less affected than some of the more popular cities, but in the event that this continues to rise in number of cases, what is the anticipated recovery like in the next several months as you restrict some of these restrictions, as you lift some of those restrictions, and are you prepared and do you have resources to prepare for a possible additional spike in the number of cases with mortalities?
Yeah, that's a nice question. We progressively return to schedule some elective case. Still, some patients are reluctant to do the surgery right now. So, but the very symptomatic patients want to have the surgery now. So we have the surgical consent form to explain all the complication, not only by the surgery itself, but the additional complications of COVID. Right now, we are starting to schedule patients with neurological deficit or severe and refractory pain, patient that is not classified as risk group, and every time that you can do a MIS surgery. So the idea is same day or next day discharging the patient from the hospital. So this is a progressive growing on elective case. We have some barriers that we need to have more COVID tests for all the patients. The protection, the equipment to protect us, we need more protection and more the number of negative pressure rooms in the hospital. So we balance how can we give us a surgery that is safety for the patient and same time have all the equipment and the surgical technique. One thing that I learned from this is that we need to be involved in all administrative and healthcare decisions, not only in surgery. Otherwise, it's going to be difficult to have this planning happens on the weeks and months. So I had several different meetings with the Secretary of Healthcare System and hospital mayor, and we work in multidisciplinary team and with different ways of thinking, but one common is the good thing. One common gives the speed and increase the efficacy. So that is the point. A lot of meetings to strategic planning the recovery of all the elective case. That is the good thing.
Excellent, Dr. Salavina. Next, I'm going to ask Dr. Scott Kreiner from Phoenix, Arizona. It looks like you guys are starting to list some of the restrictions as well as locally compared to other parts of the U.S. Do you guys have any protocols in place, and what's your recovery looking like from your medical practice physiatry standpoint? Do you foresee the continuation of telemedicine as your predominant method of consultation? And what about the procedures that were placed on hold previously because of the restrictions?
Good question. So in our state, our governor placed our elective procedures on restriction because of concerns about PPE more than concerns about the spread of the disease. So if the cases required a mask, gown, gloves, the concern was that we would run out of PPE to care for patients with COVID-19. Initially, it was thought that would cover all procedures, not just surgical procedures, interventional procedures, injections, and everything else. As it turned out, gloves weren't really an issue, and so the governor allowed all minor procedures without, with the use of just gloves as the primary PPE to continue. So we've been able to do epidural injections and other types of procedures in our state. Because the impact on the healthcare system hasn't been quite as high as we thought it was going to be, because of social distancing and the other measures that we've taken, as I mentioned earlier, the governor is starting to lift the restriction on elective surgeries. They're not opening up the rest of the state yet and other businesses. And as they do this, what they're requiring is they're requiring certain certain requirements from the facility. So that each facility needs to demonstrate that they have PPE adequate for 14 days to take care of patients. So if they don't have at least 14 days worth of PPE, they can't do elective procedures. If it's a hospital where they're going to be doing the surgery, they have to have a bed availability of no greater than 80% of total bed capacity. So they have to have at least 20% of their beds available. They need to test all incoming elective patients for COVID-19 and all at-risk healthcare workers prior to an elective non-essential surgery. And they need to document and have a good management of all of their PPE and COVID-19 diagnostic tests. So they're taking a lot of precautions as they start to go back into allowing some of these elective cases, making sure that we are still able to take care of COVID-19 patients should we see an uptick in the number of cases that we have, and at the same time make sure that healthcare workers and patients are protected.
Great, thank you, Scott. So final speaker on recovery would be Dr. Ter. Sounds like Dr. Ter, in Thailand, Bangkok, you guys are starting the process of recovery. Do you have protocols in place, and how are you managing your cases and your management of spine patients in Bangkok or Thailand?
Thank you, Patrick. We have learned so many things from the COVID-19 infection. The first of all, we think we cannot believe in the patient history or the patient history. one of our member in Thai Spy Society have emergency case, the foreigner in Phuket Island. They broken their C-spine and have the C-spine injury and quadriplegia and need to do surgery as fast as possible. The patient said the patient said that he doesn't have any risk. He doesn't go to anywhere around the Phuket Island. But after the surgery for 3 days, the patient have fever and the test for COVID-19 is positive. So we have learned so many things that for the emergency case, we need to do a protection as much as possible, the fully protection as much as possible. We cannot believe all the history. The second thing is about the elective case. We just have the news policy from the hospital because we have evidence that even the patient have negative PCR for COVID-19 and we do the operation already. 1 or 2 weeks later, the patient also can infect with the COVID-19 after their recovery and discharge from the hospital. So right now, my hospital, my private hospital, they have the new policy to check COVID-19 PCR and also COVID-19 antibody 2 times before elective surgery. They separate 1 week. If the patient have negative COVID-19 antigen and antibody 2 times, they are allowed to do. The hospital director will allow us to do elective case. But for emergency case, every people need to wearing the fully suitcase during surgery to protect our medical personnel. Anyway, in our country, we have only 0.2% of the medical personnel who infect with the COVID-19 take care all the people who infected with COVID-19. The problem of our hospital, which will be faced in the future, is about the number of the patient, which is significantly dropped the number because Thailand is the medical hub, which Arab and Southeast Asian people, they fly in and doing the elective case in our country. So in my hospital, Bangkok Hospital, 65% of the case, this is a flying case. This is a foreigner case. Right now, because of the government was shut down and restrict the foreigner to come in, so we have nearly 0 flying case. Only Thai and expat foreigner who living in Thailand is coming. But anyway, we heard that in the few weeks, maybe 1 or 2 weeks, next 1 or 2 weeks, our governor will try to restart the open, and they will have the policy to quarantine the people who come in our country. It should be fine. So I think our medical status, our medical environment, and the status should be better and better, and coming to be in the same situation in the next few months. Yeah. We hope that.
Thank you, Dr. Tayar. So we're going to move on to questions and discussions for hopefully the next 5 to 10 minutes here. We're going to start with Professor Dewano. We have a question here for you from the audience regarding testing. I think that you have brought up the issue of CT as a testing method. I know there are a number of different testing methods. What is your experience with testing that is most ideal? And with the CT, what is the sensitivity and the specificity of diagnosis using CT for COVID-19?
Thank you. Again, let me show the map, because Indonesia is the same wide like United States and mostly consists of more than 7,000 islands. So it is very difficult to control. If the case increases, maybe because the mapping is not completely done. It's not easy to detect the case in the rural area. So it is increasing. Now the first things to recovery is to stop the traveling. And now we have 34 provinces now starting to close the border between the province and also the city. And if you know that the rapid test is not mean that the patient with positive is confirmed that COVID positive. They need a swab, and the swab need some days to confirm this is COVID or not. So this is the problem. But nowadays, since tonight, the government make a strict close of the border. So the people stop to traveling only for medical or staff or certain duty they are allowed, but with the control by the police and by the military also. So that is the real problem. But what we like to have good things is the recovery of the patient now getting higher compared to the mortality, because this is a self-limiting disease. So now we have just innovation for treatment, like using the plasma of the healed patient to treat. And now we try also to use the exosome for treatment of these cases, because theoretically, after we success with the this is theoretically, this is the biogenesis of the exosome itself inside the cell membrane. They use the DNA, RNA of this, and then exocytosis, and but this biogenesis is hacked by the virus. Hack here, and then put the viral sign, and then replicate, and then come out and become so many more virus again. Then exosome is, when contact with the cell membrane, they release the messenger RNA and microRNA and so many growth factor, then stop the replication. Stop the replication. So the other thing is they will also stop the cytokine, and they also can regenerate the cell and then make a new regeneration, like the theory what we do for the paralyzed. So that is the situation in my country. It is still increasing. Hopefully with this lockdown, partially lockdown, it will be controlled. Thank you.
Well, thank you, Professor Turano, for giving us an update on the treatment with exosome. We'll love to hear more about it. If I could address the same question to Dr. J.C. Wu about testing, because I think that's a critical issue here. It sounds like most of the testing that's being done in Taiwan and even in some of the other areas is using RT-PCR. What about antibody testing for immunity, and what about CT scan of the chest or lungs to diagnose COVID-19? What's been your experience in the various foreign testing?
Right. Thank you, Patrick. I think one of the good things that the Taiwanese government has done very well is that they tested, they screened these suspects very effectively. Because for any country there's a certain capacity of testing, right? So they focus the test on screening test on those who have risk factors. For example, whoever has contact history, whoever returns from overseas, and or who's febrile. So so far the positive rate of our testing is only less than 1%. So basically we caught most of the COVID-19 cases early. The good thing about stop the transmission is you caught it early, and they said that there's some research saying that the patient will be most infectious or contagious in the first 5 days, or even 1 or 2 days before symptoms occur. So it's very important to run this screening test, and I suggest screening tests for those using RT-PCR for those have risk factors. And regarding, you mentioned that antibody tests, and the government has using the antibody test to screen for those who possibly have remote infection, which means there are certain asymptomatic patients, whoever, or mild symptoms, they recovered from the COVID-19, and but they in their serum they're still antibody positive, but they might have negative RT-PCR. That means they don't have any virus load, or the virus load is very, very low. So at that time, then we can use the antibody tests. And regarding, you mentioned a CAT scan, I think CAT scan might be it's a good way to for diagnosis of COVID-19 pneumonia, but it will cost, as we can imagine, it costs in transmission or contaminate of the radiology equipment or radiology scanning rooms. So I think using CAT scan is not very efficient so far. So I think I advocate the wide use of these testing screenings, especially for those high-risk patients. And there are several cases who had the first test, first RT-PCR negative, but turned positive at the second or even the third time. So, and one thing that the Taiwanese government has done very well is that they only let the patient go back home once they have 3 times of RT-PCR negative. That means the virus is completely gone. Then for those patients, so far we don't have any recurrent. That means that we don't have any one turn back to positive after the 3 times negative of COVID-19. That's our experience here in Taiwan.
Thank you for your answer, Dr. Wu. So we're running a little bit over on time, but we get some excellent questions I'd like to have our speakers address quickly if we can. So our next question is directed to Dr. Sahil. With the shortage of N95 masks, do you reuse it and sterilize it? And what are you guys doing with addressing the shortage of PPE equipment?
Patrick, is it me to answer the question?
Yes, please answer the question, Dr. Sahil.
Well, we had some problem with the PPE and the mask, and what we are doing is we use N95 or near about the mask, and we kind of rotate it. We use it from morning, evening, and then we use a new one from the second day and another one on the third day. and that mask is not discarded on the day one. It is kept in isolation, which is in a dry area which is not moist, and it's room temperature. Hopefully that any virus which are loaded there on the mask or the both front and back, they die over the period of time, because I understand that the viruses, they disappear or they die away in about 12 to 24 hours. So I think that's a reasonably safe period if you leave the mask to be used for after 48 hours, 72 hours. You could gamma radiate it, but I think that's not all the time practical. Or you could use a new mask, which is surgical mask is available, but N95 or the near about, they are not freely available. They are expensive. They have to be imported. But we are coming up to that. The body protective equipment, we have two kind of sort of overalls or garment. One is a disposable one, which is made of paper, the same grade, medical grade gowns and etc., or the tunic you wear during surgery. The other one is washable one. Most of the people now, they are using washable one, which you can wear from morning till evening, and evening when you go home, or when you go, once you finish your shift or job, you can just wash it off and let it hang out, and in the morning you can wear it again once it's dried up, and it is it is hopefully contamination free. And the other thing which we are facing at the moment is lack of testing facility, which is, I think, significant, and that brings the number of the patients which are still on the lower side. I think it's the number of patients which are tested, they are low in number. The second is the treatment for the severely sick patient. We have isolation wards in the government hospital, and also in my private hospital, we have a separate floor with the negative pressure air conditioning, and we are taking care of that. The other thing which we are looking forward is the passive immunization. We are running into a trial of passive immunization with a patient who has been exposed. They have antibodies. You do the plasmapheresis, and then you inject this antibody, gamma globulin from that patient who is infected and is recovered from the infection, and then you inject that into another patient who is in need of those gamma globulin. Again, it is not a straightforward treatment. We, few of our colleagues are working on that, and I think they have just started a trial on this patient who has recovered, and they are injecting this gamma globulin to the patient who need it, especially those who are sick patient and they need more sort of supportive measures. This is still in the initial phase, very difficult to say, but theoretically it sounds good. The other thing which we are looking forward from, not from our own country, but we're also working on the vaccination, but I think all the advanced countries and their advanced labs, including Europe and China, we're looking for a vaccination drive, and I think hopefully with passage of time, some vaccination will come on the horizon, and it will protect those people, because the current scenario in either in the Asia or the other country, it's not going to go away, this pandemic, over the period of time. So we have to have some vaccination which needs to be instituted and propagated, so that the rest of the patient or the population is protected. I think Darbono's conditioned media or the exosome is good. I think theoretically should work, in especially where the cytokine storm is there, and that produces a lot of inflammatory response. But I don't know how effective is going to be over the period of time. There's one question to the Tayard. The patient which you had the cervical spine surgery, where you had a third day COVID positive, do you anticipate the post-operative complication rate or the post-operative clinical course same as in a post-operative, or you anticipate some complications which may be because of surgery, or maybe because of COVID along with the surgery, and you have a sort of very florid or very rapid sort of maybe accelerated inflammatory response in face of COVID positivity and infection, clinical infection, and also post-operative sort of, systemic response to the surgery and otherwise. So do you anticipate any different type of complications? And if at all, how do you think you will manage them? Thank you.
Answer Professor Sahil question. Actually, this case is not my case. It's our member in southern of Thailand. Anyway, the autopsy of the patient showed that the patient has passed away because of the COVID-19. And this is not the complication of the cervical spine injury or the surgery from our member.
Okay, excellent discussion. So one final question, since we're running out of time. I'd like to address this with Dr. Falavigna. There's an excellent question about some research that shows that COVID patients have a higher mortality, as much as 20% increase in mortality rate with COVID infection undergoing any surgical procedure. I know you're well versed in research, and you probably have some experience doing these cases. What's your comment on that statistics, and are you seeing that, and do you have worries that these patients have significant high risk of mortality?
Well, I agree with that, because that was the reason that we have a surgical form to inform all the risk of the patient, not from the surgery itself, but also that is regarding the COVID. That comes, we need to understand which patient we are doing the surgery and do all the tests before. That is very important. So everything that we said about PCR, antibody test, we should have this done before. And even if it's an elective surgery, even more, we have time to wait and to look at the patient and prepare the patient and ourselves to the surgery. So I agree, unless it's very necessary, the surgery. I run the surgery on emergency case, but all the time I wish to have all the tests to run on the patient before the surgery. And for elective case, I'm sure that we have the PCR and antibody tests before the surgery to run appropriately the surgery. And even if you have some aerosols formed by drilling, so all the equipment that Scott told us about the PPI, we need to have all the safety equipment, not only for the patient, but for us and for the staff. So we need to be prepared. This is something that we need to balance. How much important is the surgery for the patient at that time, and how much we can make us safety on that time.
Thank you for that comment. I would like to wrap up this webinar. As all of you have seen, the world is much smaller, and we're all closer to each other than ever in the history of mankind. I think that the COVID pandemic clearly has touched all the individuals in every part, in every corner of this globe today. I want to thank you for your participation, and thank all the speakers for the excellent comment and discussion regarding this webinar. For additional resources, please visit www.spine.org/COVID-19 for additional information. And this session was recorded and will be available on the website. Please be well, be safe, and stay healthy to all of you around the globe. Thank you very much for your participation.
Thank you.